Welcome everyone to our session this afternoon about building strong prenatal to 3 state systems. My name is Kathy Gillespie and I'm a member of the PDG B-5 Technical Assistance Center. We're glad that you're here today. We have a very exciting panel of presenters today to share the work that they are doing. We're going to begin our presentation today with some information from Kathy Thornburg, and she's going to share with us some about the report that's entitled Investing in the Future, State Supports for Infants and Toddlers. And then several folks from some states, Brandy Brown and Wendy Pittard from Alabama, Susan Adams and Mindy Binderman from Georgia, and Sarah Remington from Rhode Island are going to walk us through the work that they're doing in their states, specifically to build up the prenatal to 3 systems. So we're going to go ahead and get started, and I'd like to introduce Kathy Thornburg. Kathy has over 45 years of experience in education, including teaching early childhood and policy courses at the Universities of Kentucky and Missouri, directing programs, and serving on state and national research projects. She has been the Associate Commissioner for Early Childhood at the Missouri Department of Education, and she has been a TA expert with the Race to the Top Early Learning Challenge and the PDG grant in both of its iterations to date. So welcome, Kathy. I turn it over to you, and I'm going to put the link to the to the report that Kathy will be speaking about into the chat for everybody. Oh, housekeeping items. Thank you, Adam, for reminding me. Sorry. A couple of things we'd like you to do. I was just looking at my script and talking and not really paying attention. If it would help if you'll go back to the slide, Adam, about changing your name. Thank you. If you would take a second to change your name so that we can see which state you are from. And so put that in, you can see you click on the participants button. When the rename comes up, click on that and then put in your name and the state and click OK. And that would be great. I got all excitable, ready to take things to Kathy. If you're joining us from your phone, it's probably better if you are on the audio from the computer. So if you want to change that, you click on the upward arrow beside the microphone and you change the audio to switch over to computer, or you can call in from your phone if you like. There'll be instructions when you click on that. And then lastly, please use the chat to ask questions or to share your ideas. And please remember to keep your microphone muted when you're not speaking so we can cut down on our background noise. So now, in all of my excitement, it is time to turn it over to Kathy Thornburg. So Kathy.
Thank you, Kathy. And now I'm trying to share screen. I hope you can see that. Can you see that?
Not yet, Kathy.
Oh, well, I put it on share screen and the PowerPoint slide, just like we practiced, as we all have to do. And I can see it perfectly fine. So now I'm not sure what to do next.
Did you click share at the bottom once you chose the PowerPoint slide?
Yes, I did.
Oh.
Yes, I did. Now I'm trying to get out of it, back to Zoom, and start over. Share screen, PowerPoint slideshow.
Now
There it is.
Oh, there you are.
Oh, good. Well, sometimes it takes more than once, right?
There you go. All set. Thanks, Kathy.
Okay, thank you. And thank you for the introduction. And I'm so happy to be here today. And I'd like to thank, Kathy mentioned the brief. Kaylee was my co-author, so I'd like to thank her, of course. We interviewed quite a few state leaders and have input from them. And especially thanks to all of you who are working on behalf of babies and toddlers. It's really important. I just wondered, out of curiosity, here's a little poll. How many of you have in fact read the brief, Investing in the Future Supports for Infants and Toddlers, or at least glanced at it? I don't know. Adam, can they just check box here and it'll count it up, or not set up as a poll?
There's a reaction button at the bottom right-hand corner of everybody's screen. You can hit thumbs up and Kathy can see that in the participant list if you'd like to share that you've read the report that way.
Okay, I was hoping some of you had, but I know some of you have not yet. So I'm going just to present some highlights And that will make you want to read it after this session is over and after you've heard from the 3 states as well. So thank you. So this was looking at the state applications. So that's just a reminder that these are the activities that were proposed. And what we did, we took the 23 state reports and we looked for infant and toddler initiatives and found 3 major types of initiatives. One, the professional development. So this was PD for infant and toddler teachers, directors, family child care, family friends and neighbors and so forth, but also those who support those folks. The second big category was supporting parents and families, and then strengthening, looking at the systems work that states are doing with infants and toddlers. So I'm really excited to present these to you. The first category, as I mentioned, is expanding professional development opportunities. So each slide will have the activities from multiple states. So of the 23 states, you can see that this particular activity occurred in 21 of the proposals for the PDG funding. And then I have a couple of state examples on each slide as well. So in improving both in-person as well as online PD, of course, as you all know, online became more and more prevalent as time went on. But California launched early childhood cafes, and not only for family child care providers, but I think it's interesting for family, friends, and neighbors as well. And Maryland developed a series of forums for family child care providers. And I just must say, because I was so intrigued by the name, South Carolina held 2-day summits for infant toddler teachers and directors, and they called it Baby Jam. Thought that was really cute. Another PD area was expanding coaching or TA for the workforce. Colorado proposed using a telehealth approach to expand the reach to those, particularly in rural areas and primarily family child care homes. And Georgia, and you might hear more about this later, proposed to create 3 to 5 family child care learning homes support networks. Note that quite a few of these activities related to family child care providers. And of course, we all know that lots of infants and toddlers are cared for in the more informal settings and in family child care. 13 of the 23 states proposed offering courses, credentials, certificates, and so forth. Florida developed or planned to develop an infant toddler micro credential. And this could be stackable and for college credit. New Jersey expanded their infant toddler instructional certificate and added 18 hours. And I just learned the other day, actually, that Michigan has all new teacher certification content related to infants and toddlers. I think that's important as well. So another area, providing professional development for those not for the teachers and the providers, family child care providers and so forth, but for those who support the teachers and the family child care providers. Illinois proposed to train new consultants for the infant and early childhood mental health model, consultation model. And New York had PD for infant toddler specialists to have more training on not, mental health basics, but also equity, inclusion, and so forth. So these are examples of primary activities related to the PD to support infants and toddlers. Now we'll move on to supporting parents and families. So there are 5 main areas in this as well. 9 of the states talked about improving screening and referral process. Connecticut with an app-based technology for screening, and Louisiana, 2 state departments expanding their No Wrong Door to help not only early childhood programs, but centers and homes, but also home visiting programs. So screening would be more prevalent. By the way, there's much more detail and many more examples from all the states in the brief. So those of you who stated that you had just looked at it briefly or not at all yet, you'll get lots of good ideas. Another one relating to parents, this was 11 of the 23 states, how to better engage and educate parents and families. So Minnesota proposed a better identification and intervention system for those with developmental concerns through their Help Me Connect. And again, more information about that in the brief. And New York added a texting feature, or we're planning to their online parent portal and mobile app. Free text messages, and this is quite impressive, in over 100 languages. So parents or families could learn about healthy pregnancy, child development, all areas in child development, how to find early childhood programs, social services, nutrition programs. Is very, very extensive. So that may be something you want to learn more about. And then 5 of the states talked about having a stronger parent voice. The examples here: Connecticut worked or planned on working with 10 parent leaders so they could co-create a parent cabinet. And Washington wanted many more opportunities for parents to serve on these various advisory committees. So that would allow parents then, of course, to influence and lead planning efforts, implementation, also evaluation efforts across the early learning system. 11 of the 23 states talked about expanding their home visiting programs. Michigan, you see, had a validated tool to assess the strengths and gaps, so more home visiting could occur. South Carolina increased the number of families with premature or low birth weight babies participating in home visiting programs. And you may learn a little bit more about this from Alabama, but supports provided professionals outside of the education domain. Alabama proposed to provide a learning collaborative for pediatricians to focus not only on screening for autism and social emotional development, but also maternal depression, and then look at referral completions. Maryland proposed distributing outreach kits, again in multiple languages, to help families know how better to apply for these programs listed. And I also remember that New York planned to hire an early childhood transition coordinator to work with cross-sector teams. I hope that happened. And the third and final category, strengthening, aligning systems. So some of the systems work to really make a difference long-term. So 4 states were reviewing childcare subsidies because, as we know, infant toddler subsidies are generally quite low compared to the cost of care. So Oregon proposed a cost of care study, and North Carolina also was looking at their rates. Most of the states, 15, wanted to or proposed initiatives that would increase the number of high-quality infant and toddler slots. In Nebraska, through an endowment fund, where for folks to get support, they would have to provide meet high-quality criteria. And then in Washington, they proposed to provide sub-awards for those to participate in QRS, so they could in fact expand in areas where there were so few infant toddler slots. Similarly, I remember Colorado proposed providing micro grants to family childcare providers and centers for licensing, and they would provide them incentives if they were caring for infants and toddlers and children with developmental delays or disabilities. Improving state level infant toddler data systems. A lot of states talked about, well, half the states talked about different ways to improve data on their infants and toddlers. And New Hampshire wanted to pilot where parents actually would put child information into the system as they were moving from Part C to Part B. And Rhode Island to track children screened into services. So not only the screening, but then what kinds of services the children were actually receiving, the children and the families. And then, as we all know, the early learning guidelines are standards, quality rating systems, registries for the workforce, and so forth. 10 states proposed activity in this area. Kansas to hire a workforce development coordinator and then MAP, PD. And in Virginia, as they revised their early learning and development standards, really to provide better guidance for infant and toddler teachers. And the last area in the systems arena, improve coordination efforts within communities and then also between the communities and the state. And Georgia proposed to conduct a landscape analysis of how families access these services. Missouri to create regional hubs in rural areas so they could redistribute resources so more infants and toddlers could be served in these underserved areas. And similarly, Oregon revised or proposed to revise their QRS to build capacity in rural and frontier communities that again had low supply of infant and toddler teachers. So these initiatives were proposed, and I'm sure most were developed, but right as this was starting, as we all remember, was COVID-19 moved into our lives. And so in the interviews, this is what we learned. There were quite a few delays in funding. I remember one state administrator said that the legislature had to give spending authority for the funds, and COVID-19 comes, the next day their legislative session was over, and so the department did not have access to the funding for quite some time. Balancing new stakeholder priorities, for example, those states that had the departments of health with big roles in certain of their initiatives, now departments of health were changing, obviously having many more COVID-19 related activities. And so there were some changes in who was taking lead on certain initiatives, or it put a slowdown on certain initiatives because of that. We all shifted to virtual work. That was just an adjustment for everyone. However, I thought it was positive that some people were very positive about it. Opened the door for new opportunities. And an example, they would have on-site meetings around the state, and that of course was travel, time, and expenses. So when they went virtually, many more folks could join and be involved, and especially those who lived in more remote areas of the state. And then some reported actually loving the opportunity to meet people from across the state. So I'm sure some of the work has changed forever, and that's not all bad. So my final thoughts, besides looking at these cute babies and toddlers, when I think of systems, I used to worry most about the babies and the toddlers. Now, with all of the work going on, I'm actually more hopeful. And I now look forward to hearing more about Alabama, Georgia, and Rhode Island happenings. And I thank you so much for your attention.
Thank you very much, Kathy. Really excited to hear about the report. I do encourage folks who haven't had a chance to read it yet to take a look. Does anybody have any questions for Kathy? There's a comment for you.
Right, I see New York did in fact have their transition coordinator. That's great to hear. Thank you.
It is great to hear. Thanks for sharing, Rebecca. Any other questions that we would like to ask before we move on to our next set of presenters? Seeing none, then I am happy next to introduce Brandy Brown and Wendy Pettard from the state of Alabama. Brandy is the early intervention specialist at the Alabama Department of Rehabilitation Services, and Wendy is a district early intervention coordinator with the early intervention program in Alabama, and they're going to be talking a little bit about how they're using the routines-based interview and home visiting training initiatives within their birth to 3 population right now. So Wendy and Brandy, I will turn it over to you.
Thank you so much. All right, I'm going to share my screen here. All right. So my name is Brandy Brown, and I am over the comprehensive system of personnel development here in Alabama's Part C early intervention. And I'm going to talk a little bit about the routines-based interview and the routines-based home visiting initiative that we've been doing. And then Wendy is going to follow after me with some autism initiatives that we have also been doing through the PDG grant. Back in 2017, Alabama's Part C early intervention system decided to adopt the routines-based model, which was founded by Dr. Robin McWilliam at the University of Alabama, as our primary method of service delivery in our state. The model consists of the routines-based interview, also known as the RBI, which service coordinators or providers who also service coordinate and provide services would be learning how to conduct with families. And then the routines-based home visiting part of the model, the RBHV, is carried out by early intervention service providers. So the first thing that we decided to do is start with our routines-based interview training. What is it? It's actually a semi-structured interview that talks about the family's day-to-day life, and it focuses on child engagement, the child's social relationships, and independence with others. And its purpose is to create a very strong relationship with the family so that we can obtain a very rich and a very thick description of what child and family functioning looks like, and also to give us a list of family chosen outcomes that the providers can work on with the families as part of their IFSP process. So why did we want to adopt the RBI? Evidence-based suggests that it is one of the best practices that you can use in order to interview families as part of your IFSP process and your voluntary family assessment in order to get information from them that are functional and routine based. We have 8 core values here in Alabama's early intervention system, and the RBI lines up with our 8 core values perfectly. So it seemed to fit hand in hand with one another quite well. The RBI, it does include a checklist. It has fidelity checks, which you can conduct. And this kind of ensures that all service coordinators are reaching and maintaining a level of fidelity when conducting the routines-based interview, which we hope will lead to consistency throughout the state on how IFSPs are conducted with our families. The research does indicate that the RBI produces a functional list of outcomes that actually belong to the family. They prioritize those outcomes in order of importance to them, and this equally creates more buy-in from the families during their provider visits. So for the routines-based home visiting, what it is, it's just a family consultation, and it emphasizes that home visits should occur within the context of the family's routine activities. It promotes the child engagement and builds family capacity. And then it also ensures that caregivers in the home visit are helping to support, that the caregiver engagement in the home visit and caregiver confidence within the home visit is able to follow through with intervention strategies between visits when early intervention providers actually aren't in the home with the families. So it kind of places importance on the fact that the early intervention is happening throughout every day between the child and the family or the child's natural caregivers, instead of focusing on the importance of a provider actually coming in and sitting down and working directly with the child. With the routines-based model, one of the things that we had to figure out is, where do we start with the model? We decided that the best place for us to start here in Alabama was going to be with our service coordinators, because we have service coordinators who only service coordinate. So we wanted to make sure that there was a list of functional family-friendly outcomes for providers to be able to work on during their visits. We started out with what we called RBI boot camps, and these were set up as week-long 5-day boot camps. They were very intense in order to be able to train providers, service coordinators on how to conduct this semi-structured interview. Service coordinators during these boot camps were presented with information on the interview process, and then they were given the opportunity to practice conducting the model with real early intervention families that came in during these boot camps and let them conduct interviews with them. So we used the first RBI boot camp cohort to help build our coaching capacity here in the state so that those people could be trained to help coach with future cohorts that were going to go through boot camps. In Alabama, we have 7 districts statewide, and we have various programs that are in each of those districts. So once we got through that initial cohort, we decided to take the training into the actual districts and do the training one district at a time. So after a group would go through the boot camp, they were given 3 months to practice conducting the RBI in the field. And then we would send in someone to conduct a fidelity check with them. And part of that process is reaching a certain percentage on your checklist in order to be able to say that you've successfully trained on the routines-based interview, and then be able to move forward with either coaching statewide or even coaching within your district and or your individual program. So with the routines-based home visiting, we started doing a pilot program when our last group of service coordinators in the state went through the RBI boot camp, just to kind of figure out what the routines-based home visits were going to look like. Because in Alabama, some of the challenges that providers have is trying to find time in order to be able to attend trainings, taking away from the busy schedule that they have. We didn't want to make it too intensive on them. So we decided to go back into the districts and just kind of provide a training to the districts, one district group at a time. And we were going to just let them get the information. They were going to be able to practice the model. And then we were going to again begin fidelity checks on that, because the routines-based home visiting also has a fidelity checklist. We partnered with Dr. Vanessa Hinton from Auburn University, who also has some PDG grant funding to assist in conducting our routines-based home visit fidelity checks. So due to some of the financial restraints that we have within our state's EI funding system, we estimated initially that it would probably take around 8 years to fully implement the routines-based model here in the state of Alabama. So when Diana Tullier, who works for Alabama Department of Early Childhood Education System, reached out to us to see if there was a way that we could utilize some of the PDG funds, we were very happy to hear that we were going to have this opportunity, and the routines-based model training initiative was one of the biggest things that we decided to try to use the funding for here in our state. So as of right now, one of the things that we have done is we have been working on what we're going to do with our 2022 funding. And we've been able to create some routines-based interview and routines-based home visiting modules. And this is going to be used for all of our new service coordinators and early intervention providers that come into the state. And this is how they're going to be able to train on the RBI and the RBHV. We're currently wrapping up our last set of routines-based home visiting training with all of our early intervention providers right now, the live trainings that we've done. When COVID happened, we did have to take the training and make it into a virtual platform, which of course was a little bit of a hardship, but we've been able to work through it, and we've finished all of those trainings. Like I said, we'll finish it in November. We're going to be able to use the 2022 money to create some modules that are going to go hand in hand with the early intervention 8 core values that we have here in the state. We want to be able to present some parent information models for the parents that we have. And then of course, we want to be able to try to hold a developmental specialist retreat and conference. And also we want to use some of the funding next year to be able to supplement some of the coaches that we've been able to grow capacity with over the years, and utilize them to conduct fidelity checks in the state as well. During the course of the PDG grant funding that we have received over the last 2 years and continue to receive into next year, we have been able to support the Family Voices program and the Hands on Voices program in our state. We've also had a very big autism initiative that we have done in conjunction with the University of Alabama, and Wendy is going to discuss that initiative next.
Okay, thanks, Brandy. So as we continue to see a rise in children with signs of possible autism, we knew we needed to respond. So in 2018, Alabama's Part C system decided that we needed to determine the best way to meet the needs of these families while still staying true to the early intervention model. The Alabama Early Autism Work Group was formed to discover the best path moving forward for our state. So to begin this work group, Dr. Angie Barber with the University of Alabama was asked to chair this work group. Dr. Barber's continued research in early identification of autism made this the best decision to ensure a successful work group. Other stakeholders were then pulled together to include researchers, psychologists, early intervention providers, BCBAs, leaders to provide both state and program perspectives, and most importantly, parents. This work group began meeting regularly and continues to do so as Alabama's Part C system remains committed to developing these autism interventions for our families. The work group began looking at our needs, barriers, and our common goals. They soon realized that instead of determining which autism intervention model would be best to adopt, they needed to find out what does the research say and what would be the best fit based on the early intervention model that is already in place in Alabama. They began looking for interventions that were sustainable and that could be trained to other providers. The search evolved into determining what are the most effective autism-specific interventions from all of the different models that are out there. And so a crosswalk was developed of both the core values within Alabama's early intervention system and the naturalistic developmental behavioral interventions, also referred to as NDVIs. These NDVIs are the best practiced interventions for our very young with autism. And the whole goal with these NDVIs is to reduce those autism symptoms. The work identified the interventions that overlap and then chose 5 NDVIs they felt were the most beneficial while also being the easiest to train providers on. And so Alabama had already developed a solid framework for what is considered best practice in early intervention. This framework is called our 8 core values. And these core values that you can see on the left are our mantra. They are our policy. We share these core values with our early intervention families, and we always use them as our standard to ensure that everything that we are doing in early intervention is staying true to our foundation. This provided the work group with a solid base, which was key to identifying the best autism-specific interventions that would fit for our state. The 5 NDVIs that were chosen were parent or caregiver implemented interventions, following the child's lead, naturalistic teaching, modeling, and natural reinforcement. In 2019, over 200 providers across the state attended a workshop on these NDVIs. This workshop was presented by Dr. Angie Barber and Dr. Kimberly Tomany, both with the University of Alabama. However, the work group knew that the 2019 NDVI workshop was just scratching the surface and that more training would be needed if they were to build capacity for these interventions with our early intervention providers. So they began an intensive training with 7 early intervention providers, with the goal being that these 7 would become autism technical assistance support providers for other early intervention providers across the state. An additional 8 early intervention providers have recently begun this intensive training as well. And all of these providers going through this intensive training have a caseload of early intervention children, and they're actively working with these children and these families, so they're able to put this in practice on a regular basis. Most are either developmental specialists or speech-language pathologists. However, we do have 2 providers that have gone through the intensive training that are also occupational therapists. So the first cohort began during the pandemic, and so, of course, they were meeting virtually. Like Kathy mentioned, it does offer some great opportunities with us being able to meet virtually and figuring out the world of Zoom. But it did allow for different providers across the state to become trained at the same time. As well, one-on-one coaching and even fidelity checks have all been able to occur virtually with these providers. So what have we learned so far with our training and coaching initiatives? We've learned that building capacity for support for early intervention providers in the state is so important. By training providers to support others in what is best practice and in the NDVIs that we have adopted, we can ensure that we are providing the best possible services for our early intervention children and families. In addition to the training and coaching initiative, we began an autism screening pilot. We chose 4 early intervention programs in different areas of the state, and we began implementing the use of the MChat with all referred children ages 18 to 30 months of age. Using the MChat has allowed these programs to then have a dialogue with families about possible red flags. They can also talk about the use of autism-specific interventions, which are the 5 NDVIS that we've adopted, and even possible referrals for an ASD diagnosis. We were able to create priority referrals for families that qualified for early intervention services and that have a failed MChat score. These priority referrals have allowed some families to receive a diagnosis of autism in as little as 2 months' time, which is unheard of if you know anything about autism diagnosis. We created a flowchart to assist the early intervention programs in the screening pilot. This flowchart allows the programs to know when to complete the follow-up interviews of the MChat and how best to assist families after the MChat is completed. We didn't want to leave our programs just hanging and not knowing what to do, and so this allowed them to know exactly the steps to follow throughout the pilot. We also discussed a variety of ASD-related community resources and additional services for families outside of early intervention. So what have we learned so far with our ASD screening pilot? We have found that having the family complete the MChat allows early intervention providers an easier approach to what can sometimes be a very difficult conversation. All 4 of the early intervention programs involved in the pilot have stated that they plan to continue using the MChat even once the pilot is done. They have seen so much success with that. We've also discovered that early intervention is already recognizing a lot of the children with red flags for autism. We feared that some children with red flags might be missed by our developmental assessments, but that has not been the case within this pilot, which we were really happy to hear and see. For the 2022 PDG grant funding cycle, we are hoping to continue the same ongoing screening efforts. We hope to support the current autism technical assistance support providers, purchasing new necessary training materials and equipment and assessment measures, as well as connecting with additional supports of external evaluators and consultants within the community.
Thanks, Wendy. So on this last slide right here, you're just going to see mine and Wendy's information, and also Mary Beth Vick, who is over the autism screening initiative here in the state of Alabama. Unfortunately, she was sick and she could not be with us today, but her email address is here. So if anyone has any specific questions about the flowchart that Wendy showed you or any of the information about the autism initiative, Mary Beth would definitely be the go-to person for that. And that is going to conclude Alabama's portion.
Thank you very much, Brandy and Wendy, for sharing your work. There are currently no questions in the chat, but I'll be sure to alert you if there are. Next, we're going to turn our attention to the state of Georgia, just a little bit over to the east. Susan Adams, who is the Deputy Commissioner for Georgia's Pre-K and Instructional Supports Group, joins us, as has Mindy Binderman, who is the Executive Director of GEARS, which is the Georgia Early Education Alliance for Ready Students. And they're going to talk a little bit about an infant toddler coalition and some other PDG projects that specifically emphasize the relationship between advocacy and state agencies and how those can create unique opportunities for strengthening the birth to 5 system. So Susan and Mindy, I turn it to you now.
Good afternoon, everybody. I'm Susan Adams, and I'm happy to be joining you today with my partner, Mindy Binderman. We're going to talk today about how state agencies and advocacy organizations can work together to further the work of infant toddler and build a better system. As you guys know, infant toddler services are really fractured, so it's really important as we think about how to connect that system that we're thinking about how to do that through partnerships. So Mindy and I are going to talk about that today through a great infant toddler coalition that Georgia has established. All right, Mindy, I'll turn it over to you.
Great. So I'm excited to talk a little bit about the Infant Toddler Coalition, about the history and the structure. And then Susan and I will talk a little bit about kind of why it works and the way that it does. And so the mission, as you see here, is to advance the health, social, and intellectual and emotional health and well-being of infants and toddlers across Georgia. And we have a vision that all of Georgia's infants and toddlers will receive the quality care and access to services that they need in order to thrive. The coalition was established prior so the coalition is probably about 8 years old now, but in 2008, and it was really on childcare affordability and access. In 2018, we revamped the coalition, we formalized the structure, and we increased our membership, and the focus became really on infant and toddler care. And so again, we have this diverse coalition of organizations to elevate the needs of infants and toddlers in Georgia and make them a statewide priority. Because again, as Susan and as other speakers have said, raising the importance of and understanding of the needs of infants and toddlers was really key in Georgia. To date, we have about 106 individuals representing 56 organizations. And we'll talk for a minute about the structure, because the structure of the coalition became really important to how we do our work. And figuring that out was important. And I think that that's what Susan and I want to talk about today. We wanted to be inclusive. We wanted it to be a coalition that included individuals, organizations, state agency representatives as well. But we also understood that different people and different organizations would have different roles and needs. And in a coalition as big as this, with as many members, we needed a structure that made sense. So we have this leadership council that helps to guide the coalition's work and plays a critical role in resolving conflict, doing some decision making. It meets on an ad hoc basis and makes decisions just with a simple majority. There are about, the Leadership Council has a defined membership of about 18 or fewer individuals. And we make sure to have a membership of that Leadership Council that kind of is representative of both issues that we'll talk about in a minute that the coalition addresses, as well as other things. Then we have the full coalition. And the coalition right now is organized into 2 different committees, one on childcare affordability and quality, and the other on infant, early childhood, social emotional health. Anyone can belong, any membership organization, any nonprofit, private business, civic organization, or interested group can belong to the full coalition. And all membership organizations, except for consulting members that we'll talk about in a minute, must sign a membership agreement that commits to the coalition's mission, vision, goals, and principles. And in addition, they commit to designating a representative to attend meetings, sharing information with their members, supporters, and employees. They agree to be listed as a membership organization. They participate in coalition activities and respond in a timely manner. I mean, so it's not a heavy lift, but we want them engaged and supportive. But the consulting members, to me, is where it gets exciting. I've been in lots of legislative coalitions and advocacy coalitions that meet, and we talk to ourselves, and then separately we talk to state agency representatives. This coalition includes our state agency friends and partners, and we do it by calling them consulting members because we want to respect the role they play. We don't want to put them in an uncomfortable situation. We don't want, right? But we need them both as resources to give us information that we need, and vice versa. We want to share information in a collegial manner. And so these consulting members are really act as advisors to our work. They share their expertise. They can participate as much or as little as they want to. And the general coalition reserves the right sometimes to have meetings that we'll call advocacy meetings, where we don't invite our consulting members, mostly because we know that would put them in an uncomfortable situation. And so they are not included, for example, in lobbying or some of these advocacy activities. And we've just established a good relationship of transparency where we can discuss that. And so Susan, I thought maybe you would want to talk a little bit about your experience on the coalition, what's worked for you, why you participate.
I think Mindy is really smart to point out this unique aspect of the coalition with consulting members. I've worked in the department for a long time now and worked with a lot of advocacy groups. And it's always a thin line to figure out how do we support and be part of the work, but also recognize, that there are certain limitations to discussions we can have. I don't lobby. As a state employee, I work for the governor's office. And so those can be uncomfortable situations. But when we're not part of decisions, then sometimes key pieces of information are missed out of the discussion. I can sit at the table and talk about, priorities of the agency. I can talk about how federal regulations work, how you can spend the money, how you can't. I can talk about how the agency is prioritizing work. And those are important things for the coalition to hear. But then I can also choose to step out of situations and conversations that are really not a conversation or table I need to sit at. So I'm informing the work, I'm part of it, I'm happy to present. And I do a lot or participate in conversations, but I also have the right to not comment on a conversation. And then also it also gives me the ability to participate without having to feel defensive, because sometimes there are hard issues that we want to fix and are not able to fix at this time. And the coalition needs to talk about those and make plans. And we need to hear those things. But it doesn't always mean that I need to respond. And consulting membership allows me to do that. So I think it's really been something that's allowed us to bring more state agency partners to the table and to really also to the full coalition and to a lot of people that are not used to working in state government, kind of understand the process better, understand some of the limitations, and really be able to move the work forward. And I think that's been a key piece.
And sometimes hearing things in real time so that you can say, hold on, we're discussing these already, or hold on, so that everyone can respond in a collegial way, but in real time, which sometimes is nice to hear too, that organic part of that conversation. And so that's the Infant Toddler Coalition. Within the Infant Toddler Coalition, as I said, we have these two different committees that have really moved forward some incredible, exciting work. And so what we're going to speak about now a little bit in the context of our PDG grant is the infant early childhood mental health, is the infant childhood mental health work, some of which has really been raised up through the coalition. If my slide will go, which doesn't seem to want to do, but it will in a minute because I did it before. There we go.
So as we think about the mental health work, Georgia has had a lot of focus on expanding services and access and building workforce competencies around mental health. One of the things as we rolled out our PDG work and we worked on the needs assessment, as we thought about our strategic plan, we were able to have the coalition members be invited to participate in surveys and meetings. We also, coalition had the ability to give us priorities to think about as we went through those PDG activities. And one of the things that really surfaced in our needs assessment work was this mental health work. Like when people talked about across sectors where children and families were struggling, and the examples they gave boiled down to this need to really for children and for their parents to have access to high quality mental health services. And they're not accessible in Georgia. It's something we really need to focus on. So we had the coalition choose that as a priority, We had this needs assessment at the same time that was saying that. So it was really a good opportunity to work together. So as we talk about some examples from our PDG work, this is one of the things that we think in Georgia is really going to come forth as a significant cross-sector, cross-system work here in Georgia. It's also brought together a lot of different partners, bringing in partners that haven't been comfortable working in the infant toddler space, thinking about people like our Department of Community Health, bringing in our department that does mental health services, which in Georgia is the Department of Behavioral Health and Developmental Disabilities, haven't really been at the birth to 5 table. And this has been a way to bring them forward.
So we should also say that sometimes it takes more than just great partnerships to get people to the table. Sometimes it takes a great legislator. And so in 2019, GEARS worked with state legislators, specifically a legislator from Rome, Georgia, who heads our Health and Human Services Appropriations Subcommittee. She helped pass a bill that established a House study committee on infant toddler social emotional health. Now, normally I don't like study committees because study committee recommendations will, you spend all summer on them and then they sit on a shelf somewhere. But this study committee, but because of I think, sheer will and determination of Representative Dempsey, has resulted in some recommendations on infant early childhood mental health that we have actually been able to see to fruition, which is really exciting. I think the House Study Committee met 4 or 5 times. GEARS behind the scenes helped staff that committee. We helped bring in experts. We helped bring topics to be discussed, but Representative Dempsey really made sure that each child serving agency had representation at these meetings, that they spoke, that they answered questions. And I think that it made some of our different state agencies, not DECAL, our Department of, and we should have said this at the beginning, although I'm assuming that most people here know that Georgia is somewhat unique, that we have an independent state agency, our Georgia Department of Early Care and Education, where Susan's Deputy Assistant Commissioner, I get this wrong every time, but that focuses on kids birth to 5. And so certainly DECAL understands infants and toddlers and infant toddler needs and the needs of our early learning teachers and others. Other state agencies that deal with either kids throughout their lifespan or even adults more than children weren't as knowledgeable about the needs of infants and toddlers, especially when it came to social emotional health. And so the study committee kind of helped bring people to the table and keep them at the table and build relationships and some understanding that has lasted as well and has helped us, I think, with our PDG work. So Susan, I don't know if you want to talk about that at all.
You would think 18 months in, I would realize to unmute myself. So PDG was a great opportunity to think about supporting and moving forward the mental health work. We've been able to put funds towards supporting the establishment of an alliance in Georgia. We've also been able to put funds forward to support child parent psychotherapy training, which we did in conjunction with some support from Alabama and South Carolina. So, having a little bit of money and funding to put to the table and use as seed money for work has been really helpful too. And so I really feel like these 2 partnerships and these 2 projects in PDG are going to move Georgia forward in this mental health work. The other area that we've kind of worked on with PDG is the activity around increasing family knowledge. And so specifically, my department and Mindy's organizations have worked on this project because in our needs assessment, we really found that families needed more information about development And then they also needed more information to be able to use what they understood about development to make good choices. And so we've got 2 projects that I'm going to let Mindy highlight for you.
So the first project is our Family Ambassador project. It was inspired by a early learning ambassador project program that Gears has in the city of Atlanta, where we train parents, grandparents, retired teachers, community members on child development and on resources available to families. And then these ambassadors go throughout the city of Atlanta, knocking on doors, going to health fairs, going to grocery stores and talking to parents about connecting to their children to services, enrolling their children in our Georgia pre-K program or in childcare. It's been incredibly successful and fun. And so DECAL took that program and took it statewide, changed it a little bit so that it's really ambassadors on Learn the Signs, Act Early. We've also been teaching these ambassadors how to develop social media posts. Many of them weren't social media savvy. And so we help them develop Instagram accounts and Facebook accounts and develop their own social media posts. It's helped them as leaders. It's helped them use their voices and share their stories and gain following. And that's been pretty exciting. The last thing we wanted
I would just say to Mindy, people have been a little bit interested in that because it was one way that we could shift during the pandemic from what was mostly face-to-face so that we could continue to get out the word through the family ambassadors. And it's been really powerful way to utilize them. And what we did is also continue to support them through stipends for a certain number of posts. They had to be approved. They had to use certain language. And so that's been really successful.
We also think that that's such a great way of building parent skills. And so we're excited about that for so many reasons. Briefly, because I know we're about to run out of time and I don't want to forget our family-friendly licensing reports. This is something we're both at Gears and at DECAL really excited about. We're working on a way of making licensing reports more understandable and family-facing. And so that we developed a childcare licensing dashboard that helps families understand what these big reports are, why they're important. You know, before you could go to a website and look, but you didn't understand if someone had a violation, if it was an important violation that affected childcare quality or safety or not, what it looked like, what the jargon and vocabulary of these licensing reports meant. And so we developed, we're leaving the reports. We have to leave the reports on, but we've developed a dashboard to actually make things more clear to families and make sure that providers are comfortable with that. So we have been conducting focus groups of providers and families and DECAL staff to look at how we can use this dashboard, how we can make it clear and understandable to families, how we make providers comfortable with it so that they don't think it's like something that's penalizing them necessarily, how they might use it to show when things are working really well. And so we're still in process of I think we've conducted 7 focus groups recently, and now there's a couple more we want to do. But we're really getting some great data and information that's going to make I think this dashboard popular, understandable, and another tool for parents. And that's what we want, right? We want parents to have tools so that they can be their child's best advocate. And we think that through this project with PDG, we'll get there. And we think it's going to be innovative, and we'll be excited to show it to you once it's all up and running too. So with that, I think we're at our time, but if there are questions, we're happy to answer them. Susan, is there anything that we missed?
I don't think so. You know, I would just emphasize that our work is really based on the strong partnerships that we're establishing and working, you know, through our PDG grant.
Thank you both, Susan and Mindy. We really appreciate your presentation. I don't see any questions in the chat at the moment, but again, I'll keep you posted if there are things to answer. So we're going to transition to our last speaker of the session. I'd like to introduce Sarah Remington, who's with the Rhode Island Department of Health and is the acting program manager for the Family Visiting Program. And Susan is going to talk a little bit about how Rhode Island has a really strong vision and collaboration between their early intervention program and their maternal, infant, and child early childhood home visiting program, or the McV program, to improve access to services for the prenatal to 3 population. So Sarah, I will turn it to you.
Thank you. Thank you for having me. I apologize. We were supposed to do this. My co-host, Jen Kaufman, who is our Part C coordinator, and she got called away at the last minute. But good afternoon or good morning, everyone. I'm Sarah Remington. I'm the acting program manager for our family visiting program here in Rhode Island. And I'm located at our Rhode Island Department of Health. And Jen Kaufman, my partner in crime, is our Part C coordinator for the state of Rhode Island. So we've developed this presentation together. And I'll share with you a little bit about what happens in Rhode Island. And we've titled our presentation The Parallel Process, because Jen and I and our teams like to model what we expect to occur between agencies and providers that we are responsible for and that we're working with together. So we've titled our presentation The Parallel Process, and hopefully you'll see through some of our presentation just how we model that. Okay, so a little bit of an overview of what our early childhood landscape looks like in Rhode Island. And I should say we call our home visitation programs family visiting programs. The reason being that when we did focus groups a few years ago, trying to understand low engagement rates in some of our family visiting programs, we learned that people did not respond well, and parents did not respond well to the term home visiting. They thought we were child welfare, and it had all kinds of negative connotations, that term. Some families also told us they did not have their own home to welcome a visitor into. So after a lot of testing and focus groups, we rebranded ourselves to family visiting. And we have an umbrella campaign called Love That Baby, which our programs fall underneath. So we are Rhode Island. We're small. We can drive across our state in 40 minutes. Jen and I see each other on a regular basis. But we have 9 early intervention providers in Rhode Island that serves over 4,000 families, which is about 7% of all kiddos from birth to age 2. We have a Healthy Families America program, which started through the McV funding and the Affordable Care Act back in 2010. We also have 9 providers of that program, and we have the capacity to serve 870 families statewide. Parents as Teachers, 8 providers with the capacity to serve 701 families, and Parents as Teachers is in part funded by the Preschool Development Block Grant funds. We have 1 provider that does Nurse Family Partnership that serves the entire state, 6 early Head Start providers, and 5 First Connections providers. First Connections is our short-term public health nursing program that generally goes in and does 1 to 3 visits with kiddos. Most visits are soon after a child is born through an automatic referral process, but we see kiddos and families prenatal to age 3. So we have a lot of collaboration within our agency. I think because Rhode Island is small, most of our agencies have more than 1 program within their agency, which allows for deeper collaboration. We have 2 agencies that have 3 of our family visiting programs plus early intervention, 2 agencies that have 2 family visiting programs in EI, and then one agency that has 2, sorry, I should say 4, 3, and 2. But we have a lot of agencies that are overlapping with each other, which we think really deepens the collaboration across agencies and between programs. So Jen and I and others have worked on a strategic plan for quite some time for family visiting that was very intentional in including early intervention and early Head Start. And we wanted to improve the collaboration not only amongst our agencies, but also amongst ourselves at different state departments. We have a saying that we silo bust quite a bit, and we are committed to doing that. So we have a Family Visiting Leadership Council that is co-chaired by myself and Jen that meets quarterly with a steering committee that meets monthly. And as we were preparing this, we got together a lot of folks that wanted to provide input, including representation from 5 families. We had 10 state leaders, a bunch of home visitors participate, a healthcare provider, some home visiting supervisors, and 5 generally agency vice presidents that were participating. So our vision for our system and our leadership council was really developed by the parents that are participating in our programs. We had a vision that we've adopted to, which is to empower parents to advocate and support for the development of their children so that they can grow, learn, grow, and find success. And that's really the heart of all of our work and what we do together and what we do in our own individual programs. We developed some shared principles as a group as we began to implement this leadership council with really, again, modeling what we wanted our agencies to practice with families. So the families are the heart of our services. Relationships matter at all different levels. So the relationships between Jen and I matter, the relationships between agency heads matter, and it trickles on down to the workforce. And then ultimately the relationships between families matter. We have a very strong commitment to health equity here in Rhode Island. So we want to always make sure that our services that we provide are not only high quality, but they're able to be accessed equitably, that they're equitably provided, and that they're valuable and accessible to families. We also acknowledge that all families have strengths, and those should be at the forefront of the services that we're providing. We also know that if we don't support our workforce, we're never going to be able to support families. And the COVID pandemic has highlighted that. You know, family visiting and early intervention never stopped providing services, even when COVID was at its peak here. And that's really taken a toll on our workforce. So we are more committed than ever to working together to support our workforce and that they feel valued. And we'll talk a little bit more about that. Our programs and our agencies are embedded in their communities and their cultures. If I had a map to show you, you could see that all of our agencies are pretty evenly distributed amongst the state, and that there's generally an agency providing one or more supports in our bigger communities. And that we take responsibility at our level and at the agency level to align and coordinate our services, but also strive for continuous improvement. We have a very rich, deep culture of CQI, not only within family visiting, but also within early intervention. I think our teams would probably say that we do a lot of CQI, maybe too much, but we are always striving to support families and improve the way we do that. So Jen and I are very committed to improving not only service delivery, but how we do things in the course of visits. So you will always hear us talking about CQI as much as we can. So we've established some priorities between early intervention and our family visiting programs. And again, we have now established a state level system to improve the coordination across state agencies and within family visiting programs to more effectively serve families and their children. Jen and I talk about this all the time. We meet regularly to see how we're doing. And we also get parent input on how we're doing. We are working really hard to increase family engagement and access to our family visiting programs. And then priority 3, which is at the forefront for a lot of us these days, which is increasing staff recruitment, retention, and quality. Rhode Island has a little bit of a workforce issue right now with early childhood. And we're working hard to not only retain the staff we have, but to attract new staff to support families. So we developed a governance structure to streamline coordination that would implement our shared priorities, and also one that looked at performance and progress. So we share data often and on a regular basis, not only within the council, the leadership council and at the steering committee, but also amongst ourselves. So like I mentioned, we have a statewide steering committee that meets monthly. The council as a whole, the larger council, meets quarterly. We have a very robust and dynamic family visiting council, or we call it the Parent Caregiver Council, which we're also fortunate to receive some PDG funds for. That meets a minimum of 10 times a year. But the wonderful thing about this group is that since it started, it has insisted on meeting monthly because there's so much to talk about. And they love working with each other. And then we have a family visiting workforce that meets quarterly. That is chaired by one of our parents as teachers providers and also one of our early intervention providers. Jen and I talk often about shared policy development and have worked on shared policies and procedures. And again, that's been highlighted a lot during COVID. We've developed shared visiting guidelines and safety protocols for our home visiting workforce so that they can visit families safely. And we share our resources and build and pool our resources together so that we can support our workforce, which we'll talk a little bit more about. So our family visiting council activities, we've had lots going on. We have data sharing that we've used to improve engagement in some of our cities that were identified not only in our 2020 McVie needs assessment, but in communities where early intervention has wanted to increase engagement. We receive ongoing input from parents and our workforce through our different systems. Again, I mentioned the home visiting guidance for COVID-19 safety. And tomorrow we are super excited. We have our first ever joint Family Visitor Appreciation Day. Because we can't all be together because of COVID, we are doing a virtual day. So we've developed a celebration in a box that was designed by early intervention and family visiting staff with a motivational speaker via video. We have a game. I know it's fun via Zoom. Lots of superlatives for our workforce. Our agencies are also handing out champion awards to support those that have supported them. And we have a proclamation from the governor of Rhode Island declaring tomorrow to be Family Visitor Appreciation Day. And hot off the press, we just received a proclamation from Prevent Child Abuse America, also celebrating our family visiting workforce in Rhode Island. So we're super psyched. It's not the greatest picture of our proclamation, but there are some of our breastfeeding support dolls sitting on top of our proclamation from the governor. So ongoing collaboration. We do so much collaboration. We were kind of trying really hard to figure out how we would fit it all in a couple of slides in the time that we had. Our First Connections program that I mentioned, it's our short-term public health nursing program, but it's also our Child Find program in Rhode Island. And First Connections goes out and provides developmental screenings on children and does refer them to early intervention. Both First Connections and early intervention receive referrals from our child welfare department. And we go in and screen to make sure that our most vulnerable kiddos are linked to early intervention and necessary supports. We have most of our funding for the long-term programs, the evidence-based models, comes from the Maternal Infant Early Childhood Grant, with some of our PAT program also being funded by PDG. But we have those two federal report performance measures that the early intervention staff have really been critical on supporting. I can't say enough about how they have supported our workforce in not only knowing how to conduct a developmental screening, but also giving them feedback on how they're doing with doing the screenings and really supporting them in adapting to a virtual landscape. Most of our visits right now are still virtual, and our teams expressed a lot of frustration with trying to do the ASQs in a virtual landscape when COVID hit. So we've been able to use our Learn the Signs Act Early Ambassador and partnerships with our own early intervention agencies within communities to support their workforce. We do have community-based teams called local implementation teams where we get together, talk about data at the community level, coordinate resources, learn about other resources in the community, and family visiting and early intervention participate in those together. And we couldn't do anything we do without a data sharing agreement. So family visiting and early intervention have a data sharing agreement so that we can share data. We can also take advantage of a statewide system we have called KidsNet, where family visiting participation data and early intervention data is also there. So we can see if a family is involved in one or the other. And those with the appropriate level of access, like pediatricians, can also see if a family is involved in one or both, so that we are not referring a family that might already be involved in one of our supports. And we love professional development as much as we love CQI. So we have a lot of shared professional development opportunities. There's actually one going 10 feet away from me going on infant nutrition and feeding right now that our family visiting and EI workforce are participating in. Our professional development training coordinator on the family visiting team works very closely with her counterpart at the early intervention state office to coordinate professional development. And some recent ones we've done have been Brazelton Touchpoints training, safe sleep training, and training on working with substance exposed newborns and their families. We also have a close partnership with our Learn the Signs Act Early Ambassador. And like I mentioned, they have been especially valuable in helping our teams transition over to doing ASQs virtually during the pandemic. So I am last, so I went pretty quickly in case there was room for questions or any other comments.
Thank you, Sarah. I don't see any questions in the chat right now, but I will pause for just a moment and see if anybody has questions for any of our presenters before we wrap up this afternoon. Not seeing any then, we'll share a few resources that we have available for you to consider. So you can find many of the things, including the report that Kathy shared today, a link to that on the PDG B-5 TA Center website. And there are many things where you can, many resources where you can browse by topic. You can see in the tiles there that there are just different topics. And once you launch yourself into one of those areas, there are many resources for you there as well, some of which were mentioned in our conversation today. Then additionally, just if you have any questions or if you want to subscribe to the updates that come out of the Office of Child Care, which is where the PDG B-5 TA Center is funded from and lives in, you can subscribe to their email announcements and stay up to date on some of the other pieces of work that are happening within the Administration for Children and Families and the Office of Child Care, and see how that meshes with what we're doing in the PDG B-5 Center. If you have any additional questions for us that you would like to have answered about the PDG B-5 Center, you can see the email there in the middle with the SRI address. And finally, the Child Care and Early Education Research Connections is a great place, again, to look for policy relevant research, things that may be able to help you in your work in the state, in your states, as you're searching to develop and strengthen your prenatal to age 3 systems. Again, a really simple place to go look by topic for things that you may be interested in. So seeing no more questions or comments in the chat, I'd like to thank all of our speakers from Alabama, Georgia, and Rhode Island today. Thank you for your time and sharing your work with us. And I'll wish the rest of you a really relaxing and happy afternoon. Thanks again for joining us.